earlier. So we are the Rotherham pediatric team, and we are going to present our diabetic QI journey. Our team consists of three medical consultants, administrator Rachel, and we have three diabetic staff nurses, Terry, Michelle, and Laura, along with one clinical psychologist who does about zero point 0.2 per office time per week. With dietitian Janet Gom and another dietitian is on mat leave. We have two link nurses within our team, Joe and Hannah as well. So why we are here, our mission statement was to support our patients living with diabetes to live the life they aspire to every day and today by building their knowledge, skills, confidence, and resilience. Our improvement journey so far, the first part of our QI project was to roll out the DigiBete app within our team and with our patients in order to use that for multiple purposes. In October, we started using the DigiBete app. We went through our training sessions ourselves within the team so that we are aware of how to use the DigiBete app within our team itself. And in December, we started rolling it out to all our patients. Initially, before we started, our uptake was only in the 30%. Later on, through publicizing it with flyers and training pages and setup pages within the team info, we have been able to roll it out in a much better way. So currently our uptake is about 67% currently. A lot of the patients have registered it. We are encouraging them in every clinic to register with the app, and also we are signposting them to videos and educational tools in the DigiBete app itself. Along with that, we are using it out as a communication tool. We are sending out news flyers, team invitations, survey monkey links so that the patients are able to use it much more on a regular basis. The second part of our improvement journey, the second arm, was how to improve the HbA1cs and diabetes control for our newly diagnosed diabetes patients. When we started in October, we recognized that initially in the first few weeks, the newly diagnosed diabetes patients needed a lot of intensive support, both in the wards and at home as well. And we wanted to initially improve our policies. So we looked at the policies and the diabetes folder. Initially, we updated all our diabetes guidelines. We borrowed some guidelines from Sheffield, for example, the age-related carbohydrate counting informations, fact sheets we created, and our checklist as well. We also went on to create an FAQ section for our patients. In December 2020, we started implementing regular ad hoc ward-based staff training updates, and that has been slowly improving, and the confidence level of our staff is slowly improved. We also looked at the ward-based menus. We did the carb counting. We laminated some of these sheets and put it in the kitchens and put it in the diabetes folder. We also carried out a staff survey. Later on in January 2021, we started encouraging the patients to use the carbohydrate and carbs app. We secured some funding so that patients who are not able to afford it, we can provide it from our funding itself. We also did a patient survey and improved patient communications. In February 2021, we started measuring our improvement. So we created run charts of average blood glucose in every 2 weeks. In April, once we have initiated the first phase of the QI project, then once all these are in place, we started introducing our first patient presented and we started introducing the carb counting from scratch. And we are measuring patient satisfaction and HbA1c as we go along. So the fishbone diagram for our newly diagnosed patients, we split it into the various sections and we worked our way around it. It is pretty self-explanatory because we have done all the breakdowns of the things that we have discussed before. Now we move on to results. So this is the run chart for our average blood glucose for newly diagnosed patients. The top line indicates phase 1. So we had 5 patients in number. This was before we revamped our guidelines and improved the staff training for carbohydrate counting. You can see that at week 2 in phase 1, the median average blood glucose was around 12.0. And after 4 weeks, it has improved to 8.8. And slowly it has improved to 7.3 in 6 weeks. But then there is a blip in week 8 where it worsens to 9.2 as the median. And after 10 weeks and 12 weeks, there is an improvement. So that reflects the 3-month HbA1c, where there is a good improvement. In phase 2, we had 2 patients. So these 2 new patients were seen after the guidelines were revamped and when the staff training was implemented. And straight away, we can see that at 2 weeks, our median average blood glucose starts off at 10. And within 4 weeks, we have a very good improvement and it's coming down to 6.7. And then at 6 weeks, it's 6.1. And this is the only data that we have because we are still in the middle of data collection. So we don't have data for week 8, 10 and 12. But I hope that we will continue with the same sort of improvement. And also you can see that the range is quite tight as well for the 2 newly diagnosed patients. So the range, for example, at week 4 is between 7.8 to 6.4. So we seem to have really good control by implementing early carb counting, not only for our staff and for patients as well, and by improved communication with them. I'm going to present the staff survey, the patient survey results. So we had 7 new patients we wanted to survey. Only 2 to 3 patients actually responded. And the questions that we asked were the staff on the staff on the ward able to answer all the questions? 100% said yes most times. We asked the question, was the shift to carbohydrate counting at an appropriate time? And everybody felt that it was just about right. The third question was, did you feel supported by the diabetes team during the initial admission at diagnosis? And 100% said they felt well supported. The fourth question was, did they feel supported by the ward staff themselves during the initial diagnosis? And the patient said they felt well supported. The fifth question was, did they new patients feel as though they received any conflicting information at any point during their initial admission? And happily, they said no. The last question was about the timing of discharge, and 100% felt that it was appropriate timing. The next slide is the staff qualitative survey. This was done before the targeted training session in carbohydrates. So this is more like a baseline survey. Out of the around 50 ward staff, we had 13 staff who responded. And unfortunately, we couldn't get more responses, but we felt that this was quite indicative of the results. The questions that we asked was, when did the staff have their last carb counting? 50% said within the last 6 months, 25% said in the last 6 to 12 months, but there was another 20 to 25 to 30% who had it more than a year ago. These sessions was it delivered as a standalone session or as part of their mass training? Most of them, 75% had said it was delivered as a standalone session. So we are glad that a lot of them are coming and attending these standalone sessions. The next question was, how did they feel it was useful? So a lot of them felt that it was very, very useful or extremely useful. The next question we asked was, were they aware of the ward diabetes folder? Luckily, everyone said they knew where it was and they found that it was useful. We also asked them what other support and resources will they access for advice in diabetes. And all of them have said they would look at the diabetes folder, carbohydrate books, folders in the kitchen, dietitians, link nurses, diabetes staff nurses, etc. So they knew where to access the support and how to get asked for the support as well. This slide shows the confidence of the staff in terms of their carbohydrate counting. So remember, this was before the targeted carbohydrate training itself. So almost 50% of them felt that they were somewhat confident in their knowledge of carb counting. Significantly, about 30% felt that they were not confident. When we ask the question how confident they feel in supporting patients and families in carb counting, quite a lot of them, almost 40%, said they did not feel very confident in supporting families and patients in carb counting. So this is something that we want to address by improving training and improving their knowledge. Communications in QI. So we have publicized our QI role within Rotherham Trust. So this is the communication newsletters which go out within the trust. So we put out a flyer in that. Also within the departmental meeting, in the clinical audit meetings and clinical effectiveness meetings, we give regular updates about the QI project itself. Later on, we are planning to present our poster within the Rotherham Trust in the grand rounds possibly, and also trying to plan for an article in the Rotherham newspaper, which is the local Rotherham advertiser. Bright spots. So far, I think as a team, we've got very close and it has given us a lot of team working skills. It has improved our communication within the whole team. That has been achieved through weekly QI meetings. We try to do 30 minutes meetings on alternate weeks and 10-minute meetings on the other weeks. So this has been able to improve our changes and also discuss freely and openly about all the problems. The first patient we had in March actually successfully carb counted from the first subcutaneous insulin dose. So that was a very big achievement for us. The other achievement for us was the very high DigiBete sign-up numbers. So far, we are about 67%, and a lot of them are being signposted to view videos and as a communication tool as well. We have built very good relationship with the ward managers and the ward nurse educators. They are able to attend the QI meetings with us as well. This has improved the staff confidence, and we are slowly on track to improve their knowledge and confidence. All our diagnosis and supporting materials within the ward has been fully revamped and it is up to date so far. Where next? As a team, we feel that we want to continue with the QI project. We would like to carry on as much as we can because now we have learned the concepts of QI and we feel comfortable and confident about carrying this forward. We also want to embed the DigiBete app for our patients and staff for their communication and education. We can create small news flashes and newsletters via DigiBete app itself. The other thing that we want to do is our night staff, where it has been an issue in carbohydrate training. So we would like to encourage our night staff, and we are finding ways to engage them to learn carb counting. We want to continue with the patient surveys to see the ongoing improvement, and also our staff surveys. We will continue to see our ongoing improvement in their confidence levels. Challenges and hurdles. So as we know, the expert meter is being phased out, so that will be an issue in the next one. We have to find other new devices and meters to help our patients. Planning for the new normal post-COVID times. So, it will be a mixture of maybe face-to-face clinics and video consultation clinics. So we will have to plan as a team for that as well. Transition services, just like every other teams, it is a huge challenge for Rotherham, especially because of the changes in the adult side. We didn't have an adult transition consultant for a few months, and now we have one in post. Thank you very much. I'm just going to see if I can share my poster with you so that people can have a look at it.